same happening where you are. You just heard Kirtan speak. He is actually presenting a case to us, and whenever Kirtan's presenting a case, I get a little nervous and a little excited. He was just telling us in a very kind way to not talk too much in the beginning and to save our efforts until the end when the labs come back, which we will humbly break and not at all adhere to, but we'll try. Prof. Rez, how are you?
I am well. Happy holidays and Merry Christmas to everyone who celebrates. So nice seeing all of you. Today we have a holiday special VMR, and I'm just like you, Robbie, so excited to hear what Kirtan has to present, and very grateful to be able to celebrate our last RLR before the new year with you.
Sorry, I just inhaled a bunch of yogurt, so I can't follow up.
But just don't aspirate. I need you for this one.
I won't. I promise. All right, Kirtan, take it away, my friend.
Sure. So, firstly, I wanted to thank you, everyone, because I got the opportunity to present the case on this very nice day. I mean, it's holiday season. And thanks to all my friends who have joined today, Rafa, Sukriti, and Mary is there. So thank you for joining us. And okay, so let's rock and roll. So the title for today's case is A Translucent Diagnosis. So talking about the chief complaint, we have bilateral lower extremity swelling. And to give you a little bit of HPI, we have a 63-year-old female who is presenting with the past medical history of hyperthyroidism and fatty liver disease, and is now presenting with the complaints of lower extremity heaviness, swelling, and fatigue since last 6 months. The swelling had been persistent and increasing since last 1 month. She had been to many healthcare providers in the past 6 months, and she had been told that probably her protein levels were low, and that's why she was advised to consume the more protein. She denied having any improvement in the swelling after making the dietary changes. As for the review of symptoms, the patient denies swelling of arms or face or any other part of the body apart from legs. The patient denies shortness of breath, dyspnea, orthopnea, polyuria, nocturia, any rashes or pruritus in the legs. As for the past medical history, the patient has hypertension since 1 year, and the patient has hypothyroidism since last 10 years. And for the medications, the patient is on chlorthalidone, telmisartan, amlodipine, and levothyroxine. The family history is non-significant. As for the social history, the patient denies alcohol, tobacco, or illicit drug use. The patient is a homemaker, and there are no allergies. And that concludes our first aliquot.
Wow, thank you, Kirtan. And Rafa, were you able to get everything, or you have any? Oh, you have the case ahead of time. So we're going to jump right into it, but before we do, I just have to make a comment. They have a remake of Home Alone, Home Sweet Home on Disney, and it's been getting a lot of negative press. I just want to clear the air and set the record straight. It's a great movie. I think people are living in the past. I thought it was excellent. I enjoyed the hour. If you haven't watched it, highly recommend it if you have Disney Plus. In any case, now to talk about this case, what I'll do is I'll leave the edema for Robbie to tackle, and I'll just speak a little bit about this non-alcoholic fatty liver disease. And truthfully, some people call it NAFLD, some people call it MAFLD with an M, because it's really the metabolic syndrome expression of the liver, right? You have diabetes, you have weight gain, fatty liver, hypertension. The thing with NAFLD, like speaking in the United States, about 30% of the US, 30% have this NAFLD, meaning a fatty liver. And it's a minority of that percentage, but it's a large percentage that go on to have steatohepatitis. So it's like a spectrum, NAFLD, then the fat causes inflammation within the liver, leading to NASH, non-alcoholic steatohepatitis. Then even a smaller percentage of those folks who end up developing cirrhosis. Why am I saying all this? Because when someone tells me they have lower extremity edema from NAFLD, I question that, because I would want to see that natural progression of abnormal enzymes I'd want to see evidence of liver dysfunction, and then I would want imaging to show that there is cirrhosis. It's not enough to have, low protein to lead to edema. I know we're all taught that in medical school, low oncotic pressure, fluid goes into an interstitial space, and then you have swelling, but it's more than that. And so here, I just wanted to do a little teaching on fatty liver because we have to just be a little questionable of that diagnosis. And something else, it's a diagnosis of exclusion. In someone who has one autoimmune disease like hypothyroidism, although we haven't been told how this patient became hypothyroid, I wonder, could there be another autoimmune phenomenon that might be manifesting itself within the liver? Mike, to you, Robbie.
I love it. I think there's a lot of spotlight on the liver here. And that's because it's one of the three common organs that causes systemic causes of lower extremity edema. The other two organs are the heart and the kidney. And you have to be careful because with the kidney and the liver, because the edema may occur absent global dysfunction of the organ itself. So how can you get edema from liver disease without liver involvement? It's through non-cirrhotic portal hypertension, like cystisomiasis might cause. How can you get lower extreme edema from kidney disease without kidney dysfunction? It's through nephrotic syndrome, where you can have albumin loss without kidney dysfunction. But the truth is, you're anchored in pragmatism here, and the pragmatic approach is to say, this patient, we're going to have to rule her out for liver, kidney, and heart disease. But I also would encourage you to put a lot of trust in the people who have been taking care of your patients before, but to owe your patient your own independent evaluation. What does that mean here practically? It means that these diseases, liver, heart, and kidney, are common and so are often easily thought of by other providers. So if you're seeing this patient for the first time, you have to reinvent the wheel, but you might as well assume that due diligence has been done in parallel. So that would push me to go beyond the three common organs that cause edema to the other three implicated issues. And those are effects of medications, endocrinopathies, and IVC disease. So it's the 2 threes, heart, liver, kidney, and then the other 3, meds, endocrine, and IVC disease. When you say meds and you see amlodipine, you're like, uh-oh, is the amlodipine implicated here? And that is very possible and only established when the amlodipine is withdrawn and the edema resolves. Endocrinopathies, you see another hit here with the hypothyroidism. It's one of a couple of endocrinopathies, the other being Cushing's disease that can cause lower extremity edema. And the last is IVC disease. IVC disease is really important to think about because as I was telling Reza, it's so ironic. Reza and I were recording an RLR on Patreon episode, and he asked me, "Hey, Robbie, what are you reading this morning?" And I said, "Oh, I was reading about IVC disease." And I'll tell you the reasons for that later. It has to do with a case that I experienced in the ER yesterday. And I learned that IVC disease is very cryptic, highly underdiagnosed. Kirtan, highly underdiagnosed, and if anyone's going to diagnose it, it's going to be the one and only Kirtan Patolia. But you have to worry about IVC disease in many circumstances, but it's very, very hard to clinch that diagnosis. One instance that is applicable here is obesity. So obesity creates abdominal hypertension, and that abdominal hypertension can create pressure on the IVC, causing obstruction of it. It's incredible. One fun fact that I learned, how the edema in obesity improves after bariatric surgery. And that's felt to be because the pressure of the adipose tissue on the IVC is relieved and the edema improves. So that's one fun fact about IVCs. But here we're reinventing the wheel. Go back to heart, liver, kidney, and then what's the deal with the amlodipine? Is the TSH normal? And query the IVC in the near future. All right, Kirtan, back to you.
Sure. So you guys are on the right track. You have covered the common things as well as the rare things. And now this aliquot is going to be the big aliquot. So as for the vitals, the patient has temperature of 37, the heart rate of 78 beats per minute, the blood pressure of 160/98. And unfortunately, we don't have her baseline blood pressure. She was saturating at 99% on room air and the respiratory rate was 16. She appeared well and was in good spirits. She was in no apparent distress. And apart from that, head and neck examination, abdominal examination, CVS, pulmonary, everything normal. Apart from the extremity examination, which revealed the symmetric bilateral pitting edema up to the knees. And then talking about some labs, the patient's hemoglobin was 13 grams per deciliter. The MCV was 86. The WBC was 8,000 with normal differential. The platelet count was 235,000, so all within the normal limits. The electrolytes, including the sodium, potassium, calcium, phosphorus, magnesium, were within the normal range. The AST was 34. The ALT was 32. The BUN was 18. Creatinine was 0.8. Total protein was low at 4.53. Albumin was low at 2.41. Globulins were within the normal range at 2.12. The albumin and globulin ratio was within the normal range at 1.14. The cholesterol was 235. The direct LDL fraction was 172.6. The triglycerides were 108.2. The HDL was 52. The glucose was 110. The PT, INR, and APTT, that is the coagulation markers, were normal. Since we had the suspicion that what if the patient has worsening of hypothyroidism, so we checked the TSH, T3, and T4, which were within the normal range. The ESR was within the normal range. Then we did the echocardiogram to rule out any cardiac cause, as you guys were discussing. So the echocardiogram revealed normal left ventricular ejection fraction of 60%. There was no regional wall motion abnormalities. There was evidence of grade 1 diastolic dysfunction, which was attributed to hypertension. Apart from that, the patient had mild TR, mild MR, mild PAH, tricuspid regurgitation, mitral regurgitation, pulmonary artery hypertension. And the right ventricular systolic pressure was 31 millimeters of mercury, which is slightly elevated. Talking about the ultrasonography. So the ultrasonography revealed bilateral bulky kidneys with markedly attenuated corticomedullary differentiation, suggestive of parenchyma renal disease. The USC of the liver revealed grade 1 fatty liver changes. And there was no evidence of any fibrosis or cirrhosis. And talking about the urine analysis, the urine analysis pH was 6. The specific gravity was 1.02. The urine protein was present at 3+. There was no evidence of any cast or RBCs or pus cells or glucose. And we did the 24-hour urine protein analysis to clarify the proteinuria, and it revealed the proteinuria of 13 grams per day. So that was extremely elevated. And this concludes our second aliquot.
The labs are fascinating, and I will pass them on for Prof. Rez to reflect on. But I think that you can look at this exam, and this exam is very, very informative. It's informative in the sense that it clarifies that the center, the center of gravity of the disease is in the legs. And I just want to pass on one pearl and then pass the mic to Prof. Rez. Why does this patient need laboratory workup? Most patients who come in with bilateral lower extremity edema, vast majority, are actually minimally symptomatic outside their legs, and their edema does not extend beyond the mid-shins. That combination is fairly diagnostic of venous stasis or idiopathic venous hypertension. And those patients, if you're being cost conscious, should not get a laboratory workup. They need to elevate their legs and get a workup for venous reflux or venous insufficiency. So the cardinal rule of venous insufficiency is broken here in the fact that the patient has symptoms, which you can see in the HPI, but also more importantly, that their edema extends beyond the shins up to the knee. So this person deserves the laboratory workup that they got. Most instances, even in that case, laboratory workup is unrevealing, and we go back to the the idiopathic venous hypertension. But no, venous stasis shouldn't have any systemic issues and should not extend this far. All right, Prof. Rez, I'll pass the mic to you.
Awesome, Robbie. Let's tackle this one together because there's a lot of information here. And I love that pearl because, again, it tells you when you're above the age of 50 and you have lower extremity swelling, it's most likely venous stasis. But Robbie's telling you why we have to go beyond the most common condition. And then the labs also paint a different picture for us as to why this is not just venous stasis. This was almost like the case that Gerline presented, where we thought it was a peripheral seventh, a Bell's palsy, but why did the patient have twitching? What was not consistent with that? So I think here, the way that Kirtan and his colleagues evaluated this patient was to keep that framework of heart, liver, kidney, and to first evaluate those organs before moving beyond the most common causes. You see what I'm highlighting here is just frequency of disease. That requires your cognitive energy first before you move on beyond the base rate. And here, we already knew from the exam and the history that it's probably not the heart. If it were the heart, where was the orthopnea? Where was the PND? Where was the dyspnea on exertion? If it was the liver, where was the jaundice? Where was the pulmonary erythema? Where was the abdominal distension? And also, where was the jugular venous ascension for the heart? The one organ you can't evaluate on exam is the kidney. There is no specific physical exam finding that will tell you that the lower extremity edema or volume overload is due to kidney disease. You may be saying, wait a minute, how can this patient have kidney disease? The creatinine is normal. Well, remember, it's not so much what the creatinine can be normal, but look at what's happening in the actual urine. So you can go back on history and ask the patient, did you have a frothy urine? It's usually not something we ask right away, and not every patient communicates that. So what I want to do here is I want to establish the diagnosis of nephrotic syndrome, and then I want to pass the mic back to Robbie to sort of talk about the approach to that, because I think this step one of when to suspect nephrotic syndrome and how to diagnose it is very important. And then that starts the journey. And remember, with any diagnosis, we're never 100% sure, but we sort of make our case for it with some degree of certainty. So how do you diagnose nephrotic syndrome? There's a triad. And remember, whenever anyone says triad, usually the triad is not present, but I think this is one instance in which the triad is actually present. So you need hypoalbuminemia of less than 3 grams. Does this patient have hypoalbuminemia? Yes. Actually, the total protein and the albumin are low. The albumin was 2.2. It's not enough for the patient to just have hypoalbuminemia, because there's other causes of hypoalbuminemia from inflammation, from protein losing, enteropathy. So you have to prove that the hypoalbuminemia is due to kidney disease. So how do you prove that? You look at the degree of proteinuria. That urinalysis that Kirtan told us was 3+ only detects albumin. It does not detect non-albumin proteinuria. And albumin makes up the majority of the body's total protein. That's why we calculate a protein cap. Albumin makes up the majority of the protein. The problem with albumin is that's not the problem, but the physiology. It has a large molecular weight and it can't filter through the glomerulus. So when you see that there's albumin in the urine, you know you have a glomerulopathy, pathology of the glomerulus. You have to be cautious there, because many times patients may have diabetes, they may have hypertension, and they may just have a non-inflammatory glomerulopathy and some proteinuria. But in this patient who has hypoalbuminemia, has 13 grams. So if you have more than 3.5, that's enough to meet the criteria for nephrotic syndrome. This patient has 13 grams. That's so much, albumin, so much protein in the urine. And the patient has lower extremity edema. That's a triad. Edema, hypoalbuminemia, and nephrotic range proteinuria. So nephrotic syndrome is different than nephrotic range proteinuria. And this patient also has hypertension. So right now, my entire focus, I'm paying attention to the echo, and I'll wait for those to be included on the whiteboard, because you can have conditions that lead to dysfunction of multiple organs that lead to nephrotic syndrome. So we can't just zoom in and say this is only a kidney problem, but our final diagnosis has to be explaining what's happening in that kidney causing this degree of proteinuria.
Superb. I love that breakdown and walkthrough through our working hypothesis of nephrotic syndrome, which I think explains everything that we have here. I think if you were to now investigate the causes of nephrotic syndrome, you'd realize that the way we label the diagnoses tells you a lot about the condition. So the 4 most common causes of nephrotic syndrome are minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis, and amyloidosis. Those are the 4. Now think about those. Those are all histopathological terms: membranous, focal segmental glomerulosclerosis, minimal change disease, and amyloidosis. All of them are actually diagnoses rendered by a pathologist, which tells you that the vast majority of nephrotic syndrome requires a biopsy, and the biopsy helps you initiate a cascade of a workup. But that's not how real life medicine works. Real life medicine works by anticipating what the biopsy results might show so that you can begin your workup. So the first way you can anticipate is to actually use the base rate of disease. And membranous nephropathy and focal segmental glomerulosclerosis are by far the two most common causes of nephrotic syndrome. That's the base rate. What other features can we incorporate? Membranous is usually the most indolent and usually the most associated with a normal creatinine and the most associated with marked hypoalbuminemia, all of which are features in this case. FSGS, in contrast, tends to be subacute in onset and usually associated with actual perturbances in the kidney function. So that makes it less likely. Minimal change disease is fairly abrupt in some patients. That's why it's called minimal change. There's no time for the change to happen. And then lastly, amyloidosis. So amyloidosis results from AL or light chain amyloidosis, but also AA amyloidosis or amyloidosis of chronic inflammation, for which we don't see any evidence of here. There's no secondary disorder of inflammation, although about 15 to 20% of AA amyloidosis patients actually don't have a clear culprit. So what's the next step here? The next step here is to recognize that histopathology is the key to the answer, but the lack of kidney dysfunction, the marked hypoalbuminemia, and the subacute to chronic time course prioritizes membranous nephropathy. And membranous nephropathy is usually idiopathic and secondary to a newly discovered a set of antibodies, which is the phospholipase A2 receptor, which is a serological test that we can send, and a couple of other antibodies that are less common. But secondary causes are really, really important to work up. And those secondary causes are things like Hep B, Hep C, syphilis, malignancies, usually solid tumors, and then autoimmune diseases like lupus and IgG4 disease. Those are things that you would think about working up. In terms of secondary FSGS, and HIV test is in order for sure. The secondary workup for minimal change disease involves looking at the medications for possible med triggers and also querying the possibility of a liquid malignancy. But here there's another key part of the case, which is what is the cardiac involvement? And cardiac plus renal syndromes are usually because the kidney causes heart dysfunction through through chronic coronary artery disease, so on and so forth, or that a nephrotic syndrome has resulted in chronic thromboembolic disease resulting in pulmonary hypertension. But of the disorders that we've talked about so far that can cause nephrosis and cardiac complications, that's again where AL amyloid rises to the surface. So there's a lot here. We went through a lot. I'd say that to summarize, the workup for nephrotic syndrome will be informed by the biopsy results that tell you what kind of non-nephrotic syndrome this is, but you often have to initiate that workup before you get the biopsy. There are a whole variety of secondary triggers that are less common than primary idiopathic disease. Most common is membranous and FSGS, with amyloidosis and minimal change disease being distant third and fourth. All right, Kirtan, back to you.
Sure. So we will do just as you suggested, that I will give you biopsy, but probably in the next record. So first, let's do the workup. So the serologic evaluation for HIV, HBV, and HCV was negative. And since we have to make sure that there are not malignant causes leading to membranous nephropathy, we checked the carcinoembryonic antigen and the CA. So both of them were within the normal range. We even did the CT scan of abdomen and pelvis to make sure there were no malignancies and there was no evidence of any hematologic or solid malignancies. The ANA was done, which was normal. The C3 and C4 were within the normal range. The anti-Plato antibodies, as you were suggesting, we sent them and they were also negative. Then we did the serum protein electrophoresis, which was normal. So the IgA, IgG, and IgM were within the normal limits. But the serum protein immunofixation did show a very small peak of M band. But since it was very small and the results were equivocal, we went towards the free light chain assays because they are much more sensitive to diagnose any abnormalities of light chains. But in free light chain assays, the free kappa and lambda chains were within the normal range, and even the ratio was normal. And talking about the cardiac involvement, we did get the ECG, which was normal. The anti-BNP and troponin levels are also within the normal range. And maybe I would pause here and give you biopsy in the later record.
Wow. Thanks, Kirtan. I don't have a definitive diagnosis just yet. I think what you did was set us up for ruling out potential etiologies. And I think that you have to ask the question, what is the sensitivity with each of these tests? Meaning that if the test comes back negative, does it completely rule out the diagnosis that you had in mind? For example, the phospholipase A2 receptor antibodies for primary membranous nephropathy. You can look up that. I don't memorize all the test characteristics, and I don't see this problem enough to be like, oh, I know the test characteristics is 90-some%. So this excludes that possibility. I would quite frankly just Google it and evaluate it, although I'll be like keen on what the biopsy results show. With regard to the amyloid, because I thought that was a good way of linking the heart and the kidney, that's through serum-free light chains. I think there's a very important teaching point there that because it's so confusing to approach the workup of, plasma cell dyscrasias, because you have an SPEP, you have an immunofixation, you have a UPEP, and you have serum-free light chains. Just very quickly, the SPEP is looking for a monoclonal protein, like a heavy chain IgG, IgA, IgM protein. But the problem is the SPEP will not capture the free light chains. And this is when you have kappa and lambda. So you can have a totally normal SPEP and still have AL, amyloid disease, or light chain disease. So here, the serum-free light chains being negative, I really think that rules out or makes very unlikely AL amyloid, because you need these light chains in the blood to then deposit in the tissues, the kidney, the heart, to cause a dysfunction. So I think that there is one exception with myeloma where you can have non-secretory myeloma, where all of a sudden you do a biopsy, you see like a lot of these plasma cells, but you don't pick it up in the SPEP. That's a small percentage, but I don't think the same phenomenon applies to serum light chains. If it does, I'm not aware. So Robbie, I personally can't make too much more progress besides saying, like, I was worried about AL amyloid, that link of the heart and the kidney, and maybe I would consider other possible diseases that link the heart and the kidney. But based on this preliminary assessment, I think AL amyloid is less likely. And I'm very interested in what the tissue shows us when we study it under a microscope.
Maybe I'll just jump in to say, I realized we neglected to say one thing, which is if you look at the patient's glucose, it's elevated. And so you might be wondering, even though the patient doesn't have a diagnosis of diabetes, how do you know this is not diabetic nephropathy? And you don't. Diabetic nephropathy is very plausible here and might account for the large kidneys that are described, which also would be consistent with many of the diagnoses we're talking about now. But diabetes does not, in the majority of patients, result in overt nephrotic syndrome. So it can cause nephrotic range proteinuria, but does not explain the marked hypoalbuminemia and the edema here. So you'll see nephrologists attribute proteinuria to diabetes all the time, but those that have overt nephrotic syndrome require a biopsy. So just careful with that. It's a common cause of a diagnostic error. In fact, Joel Toft, one of the most famous nephrologists I know of, once tweeted the following sentence, which don't quote me on it, but it's like, a patient with diabetes is not vaccinated against other causes of nephrotic syndrome. So be very, very careful with that. Alrighty, back to you, Kirtan.
Sure. So as you can know that till now we haven't made much progress, and there is still dilemma going on that how to approach this problem. So I requested my team to get one more test, which I will reveal after this aliquot, and that actually clarified the final diagnosis. And now let's move to the renal biopsy. The renal biopsy revealed acellular hyaline material in the mesangium and capillary basement membrane, which was positive for amyloid. So Congo red was positive for amyloid deposits. And now we need to find out that what kind of amyloid is this, right? So we did the IF studies, so which was negative for kappa chain, which was negative for lambda chain, which was negative for immunoglobulins, negative for C3, C1q, fibrinogen. So these were the immunofluorescence study, which were all negative. And then we did the immunohistochemistry to make sure that we are not dealing with SAA amyloidosis, although since there are no signs of chronic inflammatory disease, it was unlikely, but still we went for immunohistochemistry for SAA protein, which was negative. So now we are in dilemma how to move ahead. So let me give you the bone marrow biopsy. The bone marrow biopsy revealed normocellular marrow with no evidence to suggest the plasma cell neoplasm. There was no evidence of increased plasma cells. And this concludes all the data I have. And then in the next aliquot, I will reveal one more data and that will confirm the diagnosis.
As always, completely stumped, but I think the kidney biopsy helps a lot. The kidney biopsy confirms that you're dealing with amyloidosis, and I think Kirtan's discussion tells you how important it is to not stop there. You have to figure out what the next letter is. Let me be clear. Once the diagnosis of amyloid is established, there is no amyloid. There's AL, light chain amyloidosis. There's AA, amyloidosis of inflammation, and then there's many other A's, ATTR, so on and so forth. So how do we find the other A? How do we find the other letter? Excuse me. We have amyloidosis, and then how do we find the other A? The other A is often established by looking at the histopathology and seeing, do we see light chain deposit? Do we see serum amyloid A, as you just learned? And so what tools do we have for that? The tools that we have are simple immunohistochemistry, and then we have a variety of other advanced tools like electron microscopy to study the accompanying protein. And so it's unfortunately notorious that immunohistochemistry and simple tests miss a subtle small amount of light chain protein. So often, if your immunohistochemistry analysis is negative, you often might need to follow that up with electron microscopy and more detailed analysis for what that mysterious protein is. So I think what I would summarize and pass the mic to Prof. Rez to see where his thoughts are at is that you've diagnosed amyloidosis and you're on the hunt for the other A, for other letter. The tests that we have are very good. Immunohistochemistry is very good for AA, but often misses advanced subtle light chain disease. So that's, I think, a whole. And then, there are all sorts of other kinds of amyloidosis, and folks in the chat are chiming in on them. A range of them are genetic, a range of them I don't understand, but I'll pass the mic to Prof. Rez to tell us more.
I'm still trying to incorporate the translucency of this diagnosis into the final diagnosis that we give here. I'll be honest, I've reached my my knowledge. I think that I only know of 2 amyloids that involve the kidney and the heart, and that is AL and AA. Transthyretin is primarily prominent in the heart and can present with bilateral carpal tunnel syndrome, bicep tendon rupture. But of the amyloids that involve the kidney, you're thinking AA, but like Kirtan said, there's no systemic disease. So the only amyloid I know, and then this is why this case is amazing, because I'm sure I'll learn and add to my knowledge base, is AL amyloid. But I don't know how you can have like AL amyloid infiltrating the heart and the kidney and not leaving any signature on your serum-free light chains, unless there's some kind of, some kind of deficiency in that test that I just wasn't aware of. Any case I've seen of AL amyloid has had like a really high, either kappa to lambda or lambda to kappa ratio. So now I am ready for Kirtan to teach us.
Actually, you guys got to the diagnosis in the final part. And the reason why I labeled it as translucent, because the labs were not crystal clear. So it was translucent. So as we know that SPEP is not definitive. Same is true for serum immunofixation. So we get the UPEP, and even UPEP was normal. So now what to do further? So now we went for urine immunofixation. So that was the test which I suggested our residents and team to go for it. Because sometimes what happens that the plasma cell clones are producing the light chains and heavy chains, but they are not producing the intact immunoglobulins. And of course, we know that free light chain assays are there, but sometimes free light chain assays are not able to detect the clones, which are very, very small, which are not even evident on bone marrow biopsy, but you can still find them on urine immunofixation. So when we got the urine immunofixation, there was definite evidence of IgG, lambda, M band, and it sealed the diagnosis of primary AL amyloidosis. And of course, the gold standard test is mass spectrometry, but as you can imagine, it's extremely expensive. And I think in the entire India, like there are only a few centers where you can get that. So we have actually sent it out, and we have even sent the EM microscopy, but it has still not come back. So it will come back later. But now the thing is that since we have evidence of IgG, lambda, M band, it confirms the diagnosis of AL amyloidosis because of certain reasons. So as we know that there are kappa chain and lambda chains, but only lambda 6 and lambda 3 subtypes are those subtypes which are more prone to form the amyloid deposits. So that kind of goes in our favor, that we have lambda deposits and not the kappa one. And then the question might arise that why negative immunofluorescence, right? So as Rabi was telling us, that the commercial seras that we have in order to detect the kappa and lambda chains, they are actually directed against the constant region of the chains, right? And when the amyloid light chains are deposited, they have deletions in their structure, so they only possess the light chains. I mean, they only possess the variable region, not the constant region. And if we have antisera detected against the constant region, then how are you going to detect them? Another thing, that when the amyloid deposits, it gets misfolded. So whatever antisera you have, it's not going to find those subtle epitopes which have deposited in the kidneys. So that's why immunofluorescence can be negative despite having subtle AL amyloidosis. But then now another question arises, that why normal bone marrow, right? So in fact, while I was going through this case, I even had a chat with our friend Jack, and I was telling the Jack that, Jack, we have this interesting case and we are going through this. What are your thoughts? So we did some literature review together, and this is what we found, that in multiple myeloma, monoclonal gammopathy of undetermined significance, we always have some evidence of clonal plasma cells, be it less than 10%, be it less than 5%, whatever it is, but we do have evidence of clonal plasma cells, right? But in AL amyloidosis, as it turns out, that in over 80% of the cases, usually bone marrow is unremarkable. So plasma cells lack any atypia or anaplasma, which is seen in MM. And the distribution of plasma cells usually in MM is, in the form of clusters of abnormal plasma cells or in the form of sheets. But this is not the true for AL amyloidosis. In AL amyloidosis, usually the plasma cells are normal, not even in the clusters. So regular trilineage hematopoiesis, there would be nothing wrong, no evidence of fibrosis or anything. So that's why the bone marrow was clear. And now another reason, that if bone marrow is clear and if we have no evidence of finding the plasma cells, then who is producing those small clones, right? I mean, who is producing the lambda and kappa chain, and to such extent that they can trash your kidneys, like 13 grams of protein per day. It's not like we are getting 2 grams of protein per day, right? It's 13 grams. So why aren't we able to detect those clones? So this is the thing, that usually there may be a clone, but you need to do the flow cytometry of bone marrow, which is like extremely advanced test. We don't usually do that. We do that only when we have evidence of abnormal plasma cells. If you don't have abnormal plasma cells on standard morphology, then why are you going to proceed to flow cytometry, right? It's just not going to work. So that was the thing. And now, as AMK was pointing out in the chat, that what about other amyloidosis? Is it possible that since patient is old age and maybe the patient has some monoclonal protein, but it is unrelated to the kidney deposition? I mean, sometimes it can happen that patient has two processes, right? But if you think about it, if the patient had TTR, then why cardiac involvement is not significant and why there is no neuropathy? Talking about apolipoprotein A1, fibrinogen, gelsolin, all other things, then they are usually familiar and they have corneal involvement and all other things. We don't have that, right? So that rules them out. And then there is this another rare thing which was like discovered in 2016, which stands for ALECT2, that is amyloid associated with leukocyte chemoattractant protein 2, which can deposit in kidneys. But the thing is that it usually involves the tubules. So you will have evidence of elevated creatinine, you will have evidence of acidosis, which we don't have. So that kind of goes against that. So putting all of this together, and of course we were in dilemma, so we consulted our hematology team, we were asking for their opinion, and they told us that they have seen this before. They have seen people having grade 3 diastolic dysfunction and still having like not even IgG kappa lambda band on urine protein electrophoresis. So this is fairly common, that in AL amyloidosis, the diagnosis can be translucent, so as to say sometimes, but as Rabi and Reza pointed out, that we have to be persistent about it and we will get to the diagnosis. So now I will let you guys discuss and then I will let you know how the patient is doing.
Oh, anyone who's listening to this will see that to see the passion that you have and the dedication you have for clarity and for persistence here. And I think, as Nalayan said, I feel that he feels like he's just done a fellowship in amyloidosis. And I also appreciate, I think, the tremendous amount of humility by which you carry yourself. I'm sure, knowing you, that you're holding yourself back and probably know 10 times more than what you're sharing with us as part of the humility and also part of your desire to teach. And I think this case is a really important reminder of two really important facts. One, base rate of disease. If you find amyloid, you have 70% chance of having light chain disease. If you find amyloid and you have cardiac plus renal involvement, it's basically a 95% chance of having AL amyloid. And the other fact is that disorders related to monoclonal protein can result from quantity issues, too much monoclonal protein, or qualitative issues. Qualitative paraprotein issues are just like prion diseases. It only takes one misfolded protein to cause devastation. And AL is not an amount protein. It's actually a qualitative issue, which is why only in a small fraction of patients do you see a large number of plasma cells in the bone marrow. And I think you're reminding of this important fact. And I think you're also reminding me of what a privilege it is to practice in places with high healthcare resources. It reminds me of a case we saw at the San Francisco VA that evaded immunohistochemistry and required mass spectroscopy for the confirmation. And I hope, for your patient's sake, that in the future this test becomes cheaper and more available, and may have obviated the roundabout, complicated way you had to scratch your head to make this diagnosis. But what I'm really struck by is your humility and your knowledge and your teaching. And I think this case is a great reminder of that, and of how hard it is to make the diagnosis of AL sometimes. Prof. Rez.
Kirtan, I just want to applaud you. I think your ability to dive deep into this world of amyloid and your ability to teach about it, really, I felt like I was listening to an expert discuss this process. I certainly didn't know 90% of what you taught. And so I am going to have to listen to this again to learn that knowledge. And I think that the persistence and in discovering the logic, like understanding the pathophysiology for me, was just absolutely magnificent. So thank you for sharing this. Thank you for your incredible teaching. And this was truly worthy of the holiday edition of RLR. Mike, to you, Sukriti, or Kirtan, anything to say?
Yeah, sure. So thank you for a kind words. And as I told you that I was taking help all through this case from, like, I consulted the check, I consulted our hematology team to just well deep that why we have this thing, right? But now we have clear that, and in fact, when I did the literature review, it became clear that in AL amyloidosis, usually this is the case. I mean, it may seem atypical, but technically this bone marrow finding is kind of typical for AL amyloidosis. You won't find evidence of monoclonal plasma cells all the time. So now how to treat it, right? So the thing is that if the patient is hematopoietic stem cell transplantation eligible, then we can move to one algorithm. Otherwise, you can move to other algorithm. And since you can see that we ordered the anti-pro-BNP and troponins because of this very reason. I mean, even on echocardiography, there was evidence of diastolic dysfunction, but still, when you do the categorization that which algorithm to follow, you have to order the serological test. And if anti-pro-BNP and troponins are normal, then it means you have favorable prognosis. So you can move along the chemotherapy pathway. And the standard algorithm is to go for CyBorD, that is the cyclophosphamide, bortezomib, prednisone, and combine that with daratumumab, which is the anti-CD138 antibody. And when you have done the 8 cycles of CyBorD plus daratumumab, you have to see whether the patient is in remission or not. If the patient is indeed in remission, then you can go for melphalan and followed by autologous stem cell transplantation. So currently the patient has completed 3 cycles of chemotherapy. The patient is tolerating it well. There is some evidence of nausea, vomiting that we usually have, but apart from that, no significant side effects of cyclophosphamide or daratumumab. So hopefully she will complete the 8 cycles, and then maybe we can do the autologous stem cell transplantation and go for the cure of this disease, and hopefully everything will turn out great.
Marvelous, marvelous. Not only are you expert in the diagnosis, but also the treatment of this very complicated condition. All righty. Before my dog goes crazy, Sukriti, take us home, please.
That was amazing. And I'm doing teaching points after a long time, and I forgot how difficult it is to keep up with Reza and Ravi, especially when Kirtan's presenting the case. But I love the case today, and it was truly a Christmas special, and I was just thinking about amyloid as Kirtan was talking, and how amyloid we associate it with the Congo red stain and the apple green bifringence, and that's so telling of Christmas. So I feel like there's not much teaching after what Reza, Rabi, and Kirtan have taught us today, but maybe I can just outline some of the salient features of today's case. So as we began investigating the symptom, Reza taught us that NAFLD, or as sometimes we can refer to it as MAFLD, exists in a spectrum with NASH and cirrhosis. And he invoked the law of proportionality while thinking about this case, and how the presence of edema in the context of NAFLD makes one think of the more severe forms of the spectrum of this disease, i.e. cirrhosis. So used the stigmata of chronic liver disease, elevation of LFTs, and evidence on imaging to clue you into this. And remember that ultimately NAFLD is a diagnosis of exclusion. So make sure to cross the other etiologies out. The center of gravity in this case was truly the edema that we got, both in terms of the history and the physical. And we think about edema as taught in the VMR in three main ways. Think of the heart, the kidney, and the liver. But the presence here of the bilateral lower extremity edema that was symptomatic, as well as its extension beyond these dimensions, made us think of some of the more uncommon causes, or the less commonly thought causes of edema. And these include non-cirrhotic portal hypertension, and then thinking about schistosomiasis, nephrotic syndrome, and then the others are medications like amlodipine, endocrinopathies, and Ivc disease. And Rabi shared this great fun fact, but I think I missed it, so I'm going to tune back in to listen to that. But he also said that obesity can increase abdominal pressure, and that sometimes causes Ivc obstruction. So while collecting the clues, we learned that so as I said, here the most concerning thing was that this patient was symptomatic, and there was extension beyond the dimensions of the lower extremity. And so in the labs, we got the, our pivot here was the UA, which showed the protein urea, and that made us think about nephrotic syndrome. And what Reza taught us today was, when do you start to suspect nephrotic syndrome? And this is one of the rare times that you actually try to look for all three parts of the triad. So the hypoalbuminemia, the nephrotic range protein urea, and the edema. And then Rabi taught us that the workup for nephrotic syndrome is informed by the histopathology, but it must be initiated before the biopsy results. And the four most common types are FSGS and membranous nephropathy, which are the most common, followed by amyloidosis and minimal change disease. And another clinical poll for us to remember is diabetes in a majority of patients does not result in overt nephrotic syndrome, although it commonly results in nephrotic range proteinuria. So as the famous Joel said, that patients with diabetes, although they're vaccinated, I'm paraphrasing, they're vaccinated, they're not vaccinated against other causes of nephrotic syndrome, or other etiologies of nephrotic syndrome. And here, while we were trying to frame the hypothesis, it was essentially boiled down to three things. It was the evidence of pathology in the heart, the kidney, and the clue to amyloidosis. And we invoked thinking about AAA and AL amyloid, because these were the two common forms that would explain amyloidosis affecting the heart and kidney. And then we talked about some of the nuances when thinking about these tests and their sensitivities, and how immunochemistry is a good test for AA, but often misses the other types. And we got all this teaching from Kirtan, Rabi, and Reza about using mass spectroscopy when this fails to work, and some of the other tests that we can do. But it was truly a case of persistence, Kirtan, rather than translucent. So that was amazing.
Sukriti, thank you so much. incredible case summary and teaching. This concludes at least RLR VMRs for this year. And happy holidays, everyone. Enjoy the time with your loved ones. Be safe. We'll see you again in the new year, or I will see you again in the new year. Robbie will see you before that. And then Rafa, is there anything for tomorrow? Are you guys doing anything? Is there a global VM? Oh, there isn't. Okay. The one time I asked the question, there is no global VMR because usually Robbie concludes here. Anyways, we'll see you guys in the new year. Bye, everyone.